Okay. So this is the segue to that other part of behavioral health transformation and how it fits in the picture, which is really the expanding civil and criminal court systems and the pressures that those are creating and reshaping our systems. Um, and I'll just wonk out for a minute and you just like kick me when you're like, stop. Okay.
I probably won't kick you though.
So just, again, the MHSA was for us by us. And so it had rules that we were supposed to all adhere to in um, creating programs and services and reimagining the public behavioral health system. And it was like, look, you're supposed to collaborate with the actually impacted people. It's a mandate to include people with serious mental illness, co-occurring substance use disorders, and their families in creating these policies, programs, services, all of it. It was supposed to focus on cultural competence, by which we mean the traditional systems have never tried to learn from people with lived experience what their experience is or how to serve them. So part of that cultural competence is peers. You do not have a culturally competent mental health system if you're trying to serve someone with schizoaffective disorder and there is no one in their care team or no one in their orbit who also has schizoaffective disorder and is there to help them, you are missing something that you cannot miss and have a culturally competent system or even a competent system. Um, it was supposed to be driven by the clients, driven by the families. It embraces the understanding of wellness, recovery, and resilience, which is completely different from a notion of treatment. And if you don't get it, then you probably don't have a serious mental illness. And it was supposed to integrate the service experience. So we're trying to aim at all of these things in the MHSA, and these were in regulations. And there were important things that you were not allowed to do with MHSA funds. All the programs and services funded by the MHSA were to be designed for voluntary participation. That did not mean that if you were conserved, you could not participate in a voluntary program. You could. We didn't bar the door to you, but we were not going to use this money for involuntary court-ordered treatment programs. And it was also very clear that when the state was telling the counties to have involuntary court-ordered treatment programs, the county did not have to put these funds towards that purpose. Another very important part of the MHSA was we're not doing law enforcement with this, right? So all of these programs, even if you work in collaboration with criminal justice systems, any law in any law enforcement function and or any function that supports a law enforcement purpose shall not be funded. So what did that mean? It means, look, if you're going to do, a court-ordered mental health or SUD treatment program as criminal diversion, you cannot fund that with MHSA dollars. We're not going to allow our dollars to be sucked into the carceral system, not directly, not indirectly. And you couldn't do inpatient or outpatient institutionalization. So you could not use these funds to put somebody in a locked mental hospital, a state hospital, a private locked IMD long term. And you couldn't so that's like the sort of lock stuff. So locked or unlocked doesn't matter, right? If you have an 80-bed mental health rehabilitation center, doors unlocked, I have worked at such a place, and someone is going to live there long term, you could not use MHSA dollars to pay for that. We consider that institutionalization. It is segregation. It is not independent housing, and we're not going to let you use those dollars for that. If you want to pay for that, go find a new dollar, but these dollars are not for that purpose. So there were prohibitions really in the MHSA to prevent these funds from going into that end of the system. And what we're seeing now is that those are gone, right? The BHSA let the Department of Healthcare Services rewrite all of these rules, really semi outside the public view. And they are regulations. The state has now said, as of like last week, these are regulations. So these are going to wipe out these rules from the MHSA. So either you're going to see the state adopt the same rules, no law enforcement purposes, no institutionalizations, no involuntary programs. If you don't see that prohibition, it is gone, and those funds can flow in that direction. However, they've also reserved the right to reverse course. So for advocates who think that our dollars shouldn't be sucked into any form of carcerality, there's still a fighting chance.
So let's talk about just a brief diversion here.
Okay.
Let's talk about the difference between statutes and regulations.
All right.
Because I feel like what you just said really hinges on the difference between statutes and regulations.
Sure.
And so a statute is something that's passed by the legislature, or in California, it can also come up through a ballot initiative passed by the voters. And it's basically a law, right? Whereas a regulation, or in this case, the policy manual that DHCS has been developing, will serve as regulations. Those are rules generally that are implemented by administrative agencies to implement laws, right?
Yeah.
And so they can't conflict directly with the statutory language, right, that they're implementing. And they're somewhat less formal, right? So they're easier to change.
Yep.
All right.
Yep.
So that's why when you're saying that there's advocacy opportunities there, because they are, by they I mean DHCS, is using this policy manual in lieu of writing regulations because they have a statutory exemption that allows them to do that. But the impermanence of it and the informality of it provide opportunities for change.
Absolutely. Exactly. You got two mentally ill lawyers here. This is what happens. So I use this example to explain the difference one time that between the difference between a statute and a regulation. So like a statute is a law. So if you pass a law that says the elementary school shall ensure that children can cross the street safely after school, that's the law. And then it says, and the school can write regulations to implement this law. So what that means is the school then gets to write the rules that says, in order for to ensure that children can cross the street safely after school, we are going to hire a crossing guard. And that crossing guard is going to be available between blah, blah, blah and blah, blah, blah hours at this intersection. And that crossing guard is going to have a stop sign to ensure that the children can safely cross the street. It's all these details to carry out the law. That's what a regulation is. But they have the force of law. It's the same thing. It's like we let some agencies just write laws without the legislature. In this case, the Department of Healthcare Services for the state of California gets to write all of these detailed rules, and they're really going at it. But also because they chose to do this in an informal way, those rules can change back, right? With advocacy, they can change back when the administration changes. They can really change back at any time, which is an opportunity, but it's also like kind of chaotic.
Right.
And so looking at what the state has not issued final regulations, final rules, a final BHSA policy manual is what they're calling it. They have for parts very recently. But what we're seeing is that we're not seeing any prohibitions on involuntary programs funded through the BHSA. We're not seeing prohibitions on law enforcement purposes. And they really have reversed the prohibition on institutionalization. Like that is explicitly provided for now, not on a locked basis explicitly, but on an unlocked basis, definitely. So what does that mean? It means that you can use BHSA housing intervention dollars to take a person who is conserved and under a court order, tell them that they will live in an unlocked mental health rehabilitation center or a nursing home for the rest of their lives, and you can pay for it with these dollars.
Sounds expensive.
It's expensive. And then, nerding out again, turning to care court specifically, right? So like the before times was MHSA cannot be used for court ordered programs. If you are in a court ordered program, we're not going to bar the door to you, but like we're not going to use MHSA dollars to create a day rehabilitation program that is designed for people who are in assisted outpatient treatment or care court. So they kind of did it by the back door, right? So in the CARE Act, they're like, hey, what are we going to use to fund the treatment that Care Court will order? They're like, the MHSA. Like you can use those dollars. So that's one thing that the CARE Act did, said that they could use MHSA dollars for court ordered treatment in Care Court and court ordered housing in Care Court quite explicitly. And then they also said, and by the way, these court orders to the Care Court defendant, to the person with mental illness, like we're going to order you to go to this day rehabilitation program, but our court orders are also allowed to bind the county to provide you that day rehabilitation program. And they can prioritize, the judge can order the counties to prioritize you over other people. And any, order to the county is prioritizing people over voluntary stuff. So this like really creates a problem because it's like going back to that Marin County story. What are they talking about? They're talking about these uncovered costs of Care Court and how that has a big impact on the system. And so that's where we're seeing that not only are these firewalls, these protections in the MHSA gone, but now because those firewalls are down and because all of this money that was supposed to fund voluntary stuff can not only fund the involuntary system, but people are actually prioritized if they're in the involuntary system for limited services. I mean, I think that and maybe like I talked way too much, but maybe one of the things to say too is to go way back to this graphic and ask a question. Is that enough to go around? Or are our systems still underfunded? Like even if you take 30% of all of the BHSA dollars we get a year in taxes, say it's $2 billion, and you put a third of that towards housing people, is that enough to house every person with serious mental illness or a moderate to severe substance use disorder, a disabled person who cannot house themselves? Is there enough? Say, great, we are going to double our money in FSPs by billing Medi-Cal. Is there enough to go around? And there was no assessment by the state. There was no needs assessment. Nobody said, hey, how many people do we have? If we're going to bring in all these people through the courtroom doors that aren't engaged in services, is there enough to go around for the voluntary clients, for the involuntary clients, for anyone? Is there enough pie? And I don't think there's enough pie. I don't think anybody thinks there's enough pie.
So can you go back to that, those comparative bar graphs again?
Yeah.
So maybe you can explain to me. So that was a really great question. Is there enough like in-housing interventions to house people who may be eligible for those services? How does it work when they need to reserve, I think, or they need to allocate at least 50% of the housing interventions for individuals who are identified as chronically homeless, right? What makes them determine that somebody is no longer chronically homeless and then falls into like the darker purple category, or how is that determination made? Because I feel like once you house somebody who's chronically homeless, they're not chronically homeless anymore. I mean, in theory, right? I'm not saying like that's in actuality, but
yeah, that's a good question. To quote The Sandlot, if you were thinking, you wouldn't have thought that. Just teasing you. No, I mean, there's not really a good throughput in the system, right? Because yes, we know why the chronically unhoused with a focus on encampments, that's a quote from the law. We know why some of that money was focused there, because behavioral health transformation is about getting people off the streets. And but yeah, so you have to qualify as chronically homeless in order to initially become housed, but eventually you will not meet the definition of chronically homeless anymore because you've been housed for long enough. And then what? You're right. I mean, it doesn't have a good throughput, right? Because maybe you don't lose eligibility, you just move from the light purple bar into the dark purple bar, but it begs the question, is there enough to go around? And looking at what the state has spent in the past on homeless programs, it's a lot more than this,
right?
And it didn't help very much. Maybe there's different reasons for that, but you're right, there's all kinds of questions about what this might look like long term. what if we have housed everyone who's chronically unhoused? What if we succeed and then we've got 15% of these dollars, dedicated to funding housing for someone who doesn't exist?
Right.
Yeah, there's a lot of design flaw stuff like that all over the place. But so going back to, this issue with like, what about the court systems? I mean, we really are seeing, right? So not only is the firewall down, but um, those BHSA dollars are being prioritized for people in the involuntary system. They're also prioritized in the statute for the chronically homeless, or unhoused, people who are in the justice system, people reentry, people who are at risk of conservatorship, and people at risk of institutionalization. And this sort of sounds upstreamy, but I don't think that it is. If you're at risk of institutionalization, it's because you're conserved and they're going to place you in a locked facility, or you're in care court. And so it's like pretty clear to me that the prioritization is to the same population of people who are being targeted by the expanding criminal and civil court system.
Yeah, that's what I was just thinking too. It seems like they're using as many avenues as possible to cast as wide a net as possible to clean up the streets.
Yes.
Okay.
At least temporarily.
Yeah.
I don't know if this serves people long term, but that's the idea, and like, so for instance, if you're a defendant in care court and care court orders you into housing and makes the county pay for it too, which might be the positive, right? It's a court order to the county. So, okay, but how long, like care court lasts a maximum of 2 years. So you're housed for 2 years, because the county is being ordered to house you through a court order. Your 2 years is up. Is there capacity for you? Is the county going to do it when you don't have a quote unquote entitlement through the justice system? What happens to you? There's not a lot of throughput, as you said, in all of this. It's like, well, okay, what next?
Yeah.
What next? And so we've prioritized a lot of this money to not only serve the involuntary system, but also that's time limited.
And expand the involuntary system.
And expand the involuntary system. Yeah.
And not prevent people from falling into the involuntary system.
Correct. Right. So we cut a lot of money out of prevention and early intervention.
And a lot of those non-traditional things.
A lot of the non-traditional things.
People who may not be as enthusiastic to engage in traditional services.
Right. Exactly. So we are concentrating losses in voluntary, non-traditional, upstream, preventative services in favor of housing, including on an involuntary basis, including institutionalization, unlocked institutionalization, and court ordered engagement. And we keep expanding these systems on the basis that they've already failed.
Right. But it reminds me of that argument, right? Like, oh, we don't need an umbrella because we're not wet. And, but when you get rid of the umbrella and it's still raining, you have a problem. Right. So I totally screwed up that metaphor, but you know what I'm talking about.
I do know what you're talking about. I do know what you're talking about. And I just want to touch a little bit too, like while we're here, just in our open discussion about this, I think it's, we danced around it. We talked about it recently at a statewide conference, but why did they overhaul the Mental Health Services Act? Like, what was the actual goal of that? And it was to fund all of these expanding court systems that they didn't fund in those actual bills. So like care court, like everybody's criticized care court because they're like, yo, you're spending $290 million a year on judges and attorneys and, court documents and processes. And there was no money in the CARE Act to expand treatment options, to expand housing. There was just nothing there. If you go read the CARE Act, you're like, where is this housing money supposed to come from? And they sort of laundry list all of these existing programs, many of which have now been defunded or they were one-time funded. Mm-hmm. And they're like, okay, well, how are we going to pay for it? It's over there. So it's bridge housings, MHSA.
Right. I remember like that whole argument, when that bill was pending in the legislature over, the creation of Care Court, and everyone was like, there's no money for services. Like, if you're going to order somebody into services, or you're going to, like you said, give them a laundry list of like, okay, you're entitled to this and you're entitled to that. And it's like, well, if that service doesn't exist, then
Right.
how are you going to give it to them? And then they came up with the idea, well, we'll just like make the county give it to them. And we said, well, what about all the people who are already participating in those services? Like, if you're going to penalize the county for not giving it to them, then you're basically prioritizing that population over the people who are voluntarily receiving those services, because like you said, you're not making the pie any bigger, right? And so they said their next act was Prop 1, basically.
Right.
Yeah, yes,
Yeah.
we are. That's exactly what we're doing.
Yeah, absolutely. Yeah. And that's right. And that's the problem. Like, that's one of the things that it's kind of wonkish, but people should understand. We used to have roughly two pots of money. One pot of money that would serve voluntary services, and you could not use it for the involuntary system, and another pot of money that served the involuntary system, primarily hospitals. Like, there's a lot of realignment dollars, hospital dollars, but those two buckets were kind of separate and siloed, and you couldn't mix them up. And now everything is in one bucket. We have commingled funding sources. We have one pool of money that is supposed to serve voluntary services and court ordered involuntary services. And what ends up happening is, if you bring more and more and more and more and more and more people in through the court system doors, and they're in court ordered models of care, and your systems have limited capacity, then you crowd out voluntary systems. It stops existing, right? It's like, it's a question of access. If I have a peer respite with, well, like, peer respites don't do this, but if I had a peer respite, it has 16 beds, and all 16 people in those beds are ordered to be there under care court, then where is a person who is not in care court supposed to go to engage in services on a voluntary basis? It's a feedback loop.
Right.
And that's the same problem that has always existed with the hospitals, right? We spend all our money on hospitals. We don't fund outpatient services. And so everyone decompensates and ends up in hospitals. And then they go, oh my God, we don't have enough hospital beds. Let's build some more hospitals.
Right.
And that's like literally Prop 1.
Right. Back to fail first.
Back to fail first. Billions upon billions of dollars being poured into building clinical treatment facilities that then have to sustain themselves as businesses. They have a business interest to have people keep utilizing in that mode or model of service. And here we go. Here we go again, So it's not looking good
No.
right now.
No.
Any other closing? Do you want to throw in anything about CalAIM? Managed care plans?
I feel like that's a whole other subject for
It's a whole other
another.
subject.
I mean, what? I don't even know
I
where
know
to
that I
begin.
know that the three people who are riveted by these podcasts are really going to be holding on for that managed care plan.
Well, okay, so no, you bring up a good point, and so I'll give a little teaser maybe of a future podcast episode, perhaps. So a big question out of all this, and I sort of touched on it a little bit earlier, was how do community-based organizations survive all of this? And in particular, how do peer-run community-based organizations survive? Because we traditionally do not provide clinical services. And we don't have professional staff that work for us. And so we are learning that there may be some ways through CalAIM. And so that's a whole other separate but parallel initiative that the state began implementing, I think back in 2020 or something like that, to overhaul the entire Medi-Cal system. And so, there may be opportunities on that side, on the managed care side, outside of the county operated behavioral health system. And we can talk about that. And I'm still learning a lot about what peer run organizations and smaller CBOs might be able to do. And I don't know if it will be enough for them to survive, to be honest, but it's something to maintain independence and maintain their authenticity without, getting swallowed up by larger clinical providers or being absorbed into county programs.
Yeah. And, I mean, one of the things that I think we've been scratching our heads about for a long time with CalAIM, and we still are, is the extent to which programs have been stood up in that part of the system that people with serious mental illness are eligible for.
Right.
And that's usually, like, we don't really refer to that part of the system as the public behavioral health system because it's mostly commercial plans,
Right.
like Kaiser, Anthem, that actually provide Medi-Cal. And so we're like, are you just going to send all the people that you don't have capacity for or are voluntary in the public behavioral health system over to the managed care side, over to the commercial insurers?
Right.
Because you actually do have a capacity problem. And, yes, all 16 beds at your crisis residential are going to be CARE Act, AOT, conserved, psych hold type patients, and there's nowhere for anyone else to go.
Right, right. And that's a whole other branch on the tree, basically, which is one of the things that we're sort of looking back and reflecting on is, as I mentioned, the CalAIM initiative is parallel and overlaps with the behavioral health transformation initiatives. And it's become more and more apparent that, well, I mean, I'm assuming here, but I think it's accurate that the state was intending to create services through the managed care side to replace or to offset some of the losses that of the community services and supports and the other non-traditional services that were originally provided through the Mental Health Services Act. And so, and on a positive note, those would be available to a wider variety of people who maybe don't have a serious mental illness, but may struggle with mental health challenges or are able to generally manage their diagnosis, but and even people who are struggling with other health conditions. So that's a good thing, right?
Right.
Because the types of interventions that would have that are recovery based work for everybody. But they are they may be time limited and they are now accessed through your primary care provider. And so, and a lot of the um, uh, county contracted behavioral health service providers didn't know about all of this until
Right.
recently. It's only sorting to come out recently what they may be eligible to provide on the managed care side. And so it's sort of like, we're running around trying to in zigzags trying to figure out like how we are going to survive as an organization and how the people and communities that we serve won't fall through the cracks if they've been receiving a wider variety of services from the county under the MHSA. Those services probably are not going to be available to them anymore under the BHSA, at least not through the county.
Yeah, exactly. Part of the steak and chicken analogy is that chicken is not as good as steak. It is not as
Right.
robust as steak.
Right.
It does not check in with the 5 times a week. It checks in with the 4
Right.
times a month.
Right.
So yeah, even when,
But maybe now you can have sliders over here.
yeah, you can have some sliders. Throw some sliders on there. No promises. But I think that's one of the real concerns too. It's like sort of the state has looked at it like food is food. Right. Like so we cut a bunch of non-traditional stuff out of full service partnerships, or we hacked general system to development and the peer operated, consumer operated brick and mortar services stuff funding way down, but we can bring in more federal dollars. There will be more food. Don't worry, there will be more food. And it's like, yeah, but Twinkies, you don't want to eat that all the time.
Right. Right.
Okay. All right. You want to call it?
Yeah, we're done.
All right.
Thanks, everybody.
In the next episode, we will maybe talk about managed care plans, and maybe we will show up with Oscar the Grouch avatars. We're each Oscar.
Yeah.
Haters. All right. Thank you so much for joining us. And please join us in the future if you find this interesting or valuable.
Like and subscribe and share.
Oh, that's right. Like, subscribe, and share.